Dear viewers, students, health workers, fellow doctors, this is to healthcare concern. Our topic today is placenta previa as another cause of antepartum hemorrhage. I am by the name Dr. Okello Bosco II, a specialized obstetrician and gynecologist. Our objectives main today is to define placenta previa, understand the risk factor, presentations, diagnosis, and complications. By the definition, placenta previa is abnormal implantation of the placenta in the lower segment of the uterus. Normally, the placenta should be implanted in the fundus, but when it's planted in the lower segment, it's abnormal. It represents about 0.5% of all pregnancy. The incidence is higher in early gestation than later gestation. What it means that what? Because during early gestation, the lower segment is poorly formed. So the chance that the placenta is implanted in the lower segment, therefore, in the advanced pregnancy, migration is possible. When you diagnose placenta previa in first trimester, you need to repeat the scan in the subsequent to see, one, if migration has occurred to get away with the diagnosis, or if it has not occurred, it will remain. Then the migration of placenta I've already explained. The diagram can be seen here. You will be able to see the placenta in the lower segment. Briefly about our definition, we are able to be seeing here the risk factor of placenta previa: 1, advanced maternal age; 2, multiparity; 3, previous cesarean sections; previous placenta previa; multiple pregnancy. We know in multiple pregnancy the placenta is normally big, or there are always 2 placenta. So the chances that one or it will reach the lower segment is high. We have assisted reproductive conception. We have deficiency in the endometrium due to presence of history of any like uterine scar, endometritis, manual removal of placenta, curettage, submucosal pressure. All this will lead to as a risk factors. We are going to look at the type of placenta previa. This type of placenta previa, there's ultrasound classification, which classify placenta previa type 1 or grade 1, the placenta in the lower segment, and it is less than 2 centimeters to the internal cervical os. Type 2, the placenta is reaching the margin of the internal cervical os. Type 3, the placenta is partially covering the internal cervical os. Type 4 is completely, that is ultrasound diagnosis, which will always be given by the ultrasound people. However, there is also clinical classification, which put the placenta into placenta previa minor and major. This clinical classification is very necessary in determination on which route would you take for delivery. So in major placenta previa, this is grade 3, type 3, grade 4, and grade 2 posterior. All these are placenta type major, and the type of delivery you will be able to deliver them by cesarean section. Placenta minor is type 1 and type 2 anterior. This is termed as minor. Vaginal delivery is possible. So from our diagram, this is what I put it in the diagram here very clearly. You see type 1, out the margin of the placenta, type 2, type 3, type 4. So it's very clearly seen there. And this is still the type. Marginal complete, still will complete type is type 4, partial is type 3, marginal is type 2, low lying is type 1. Clinical presentation of placenta previa, usually presented during antenatal follow-ups. Symptoms: most cases asymptomatic. Bleeding sometimes is there, and if the bleeding is there, is painless vaginal bleeding. Colorless recurrent sign, the abdomen is always stop and gaze, and when you look at the presentation, is malpresentation because the placenta has occupied the lower segment. The diagnosis of placenta previa is mainly done by ultrasounds, and good enough now with this modern day, ultrasound is common everywhere. All pregnant women are able to access ultrasound in our developing countries. Yes, complication of placenta previa. Yes, we have maternal complication. Yes, severe bleeding and hypervolemia is common. Malpresentation, we know, is common. Antepartum hemorrhage is an obstetric emergency. Postpartum hemorrhage, sometimes because the placenta are implanted in the lower segment, they can morbidly adhere to placenta, leading to placenta accreta, increta, apocreta, which is always very difficult to deliver. The fetal complication, we have preterm births, yes, as a result of intervention of delivery. Low Apgar score always at 1 minute. Congenital malformation mainly due to constriction, and then perinatal mortality. Yes, we are going to see as a common question that are normally asked in exam also, the difference between the placenta abruptio and placenta previa. So I put the characteristic, placenta previa and abruptio. By definition, placenta previa is abnormal implantation of the placenta in the lower segment, while abruptio placenta, abnormal separation of placenta before delivery of the baby. In terms of pain as a characteristic, in placenta previa, they say the pain is painless vaginal bleeding. Why that one is painful? Vaginal bleeding. The magnitude of blood loss is very minimal in placenta previa, but is very massive in abruptio placenta. Fetal heart rate is normal in placenta previa, but in heart rate is always abnormal. You can have tachycardia, bradycardia. Sometimes the fetus has already died with IUFD. Associated history in placenta previa is rarely none, but we can have abdominal trauma or distension of the in multiple pregnancy hypertension. Polyhydramnios, this can also be as what? As associated history. Coagulation in placenta previa is rare, but in abruptio, disseminated intravascular coagulation is very, 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 very high. We are now coming to vasa previa as the third cause of placenta abruptio. In vasa previa, a vasa previa described as the fetal blood vessel running through the membrane overlying the internal cervical os and below the presenting parts. This area is very unprotected by the placental tissues. We have there are these two diagrams which you should be able to see it very well. The first diagram, you are able to see that the placenta is in the lower segment, and at the same time umbilical cord is the one running over the internal cervical os, exposing this umbilical cord to trauma as labor progress. You should be able to see that. The second one, we will be able to see that in velamentous with placenta with accessory lobes, you can see that the membrane running to connect the two lobes of the placenta. Type of vasa previas. Vasa previas type 1 is secondary to velamentous cord insertion in a bilobe placentas. So there are two placentas. So membrane between these two placenta can be connected by membrane, and the blood vessel run over them. That is the second diagram. Type 2, this is from the vessel running between the lobes of the placenta with one or more accessory lobes that can be seen. And the diagnosis of placenta vasa previa is mainly done by ultrasound and is best done by transvaginal And when you put the Doppler, you will be able to see what abnormal blood flow across the cervical internal os. We have risk factors. Risk factors. One, this may include the following associated with what vessel. One, a low-lying placenta. When you have, yes, you are at risk of developing having vasa previa. Placenta previa is S1. Multiple pregnancy S1. In vitro fertilization has been seen as a thing. Then multileukoid and velamentous cord insertion is also seen as the different type. Clinical presentation of vasa previa. This is fetal blood vessels. Therefore, there is a rupture when the supporting membrane ruptured, posing significant risk to the fetus. The vasa previa may present with vaginal bleeding at the time of rupture of membranes and with the fetal heart rate abnormalities. This includes deceleration, bradycardia. At worst, the fetal death may occur. Lastly, we have our management of the vasa previa. The major complication of vasa previa is rupture of the vessel which carry the blood vessel, fetal blood to the placenta, leading to fetal anemia. A rare complication like fetal hypoxia caused by decreased compression of the fetal blood vessel by vasa type 2, but significantly the perinatal mortality in undiagnosed cases. When detected antenatally earlier, the delivery should be done by cesarean section prior to onset of labor. There are really optimal gestation age at delivery not being established, but usually recommended delivery can be done between 35 to 36. Marginal bleeds as our last causes of antepartum hemorrhage. The presentation of marginal bleeds is similar to that of placenta previa, but this occurs from the ages of a normally situated placenta after 28 weeks. The marginal hemorrhage occurs because of contraction of the lower uterine segment beneath the lower pole of the placenta. This may lead to vaginal bleeding, but the demonstrations and pathological lesion with no pathological lesion. So no fetal compromise, no association with maternal disease. Thank you very much. This is briefly all our different obstetric causes of maternal bleeding.